Welcome everyone, and thank you for joining me today. I'm Dr. Asim Hussein, and I'm excited to present to you a series of 20 multiple-choice questions with detailed explanations. Our focus will be on paroxysmal nocturnal hemoglobinuria. In this session, we'll explore key concepts, clinical features, and diagnostic approaches related to this condition. So, let's dive in and enhance our understanding together. Let's take a closer look at this case. We have a 34-year-old man presenting with dark-colored urine in the morning, which suggests hemoglobinuria. He's also experiencing increasing fatigue, a common symptom of anemia. His hemoglobin level is 8.9 grams per deciliter, which confirms he's anemic. The elevated reticulocyte count indicates his bone marrow is responding appropriately by producing more new red blood cells. The markedly increased LDH is a sign of ongoing red blood cell destruction. Interestingly, his direct Coombs test is negative, meaning there's no antibodies attached to his red blood cells. Now, when we consider these findings together, hemolytic anemia with a negative Coombs test, high LDH, reticulocytosis, and hemoglobinuria, we can start to narrow down the causes. This pattern points us toward certain conditions that cause hemolysis without immune involvement, which is key for our differential diagnosis. This case ties into our broader theme of understanding different types of hemolytic anemias, especially distinguishing between immune-mediated and non-immune causes. Recognizing these features helps us identify the most likely diagnosis and guides appropriate management. Answer: B. Now, let's delve into the classical features that help us identify PNH. These features include intravascular hemolysis, which is the destruction of red blood cells within the blood vessels. Patients often experience hemoglobinuria in the morning. That's the presence of hemoglobin in the urine after waking up, which is quite characteristic of this condition. Additionally, a key diagnostic clue is that the Coombs test, or direct antiglobulin test, is negative in PNH. This negativity helps distinguish PNH from other hemolytic anemias that are Coombs positive. Recognizing these features together, especially intravascular hemolysis, morning hemoglobinuria, and a negative Coombs test, guides us toward the diagnosis of PNH. These classical signs are essential in connecting the clinical picture to the underlying pathology and ultimately to the overall management of the patient. Let's take a closer look at some of the genetic mutations that can underlie different hematologic conditions. On this slide, we see a list of specific gene mutations: PIGA, JAK2, HFE, G6PD, and MPL. Each of these has distinct clinical implications, but today I want to focus on how they relate to the case we're discussing. Now, consider the scenario of a 29-year-old woman experiencing recurrent abdominal pain and hemoglobinuria. Her labs show pancytopenia, which indicates a deficiency of all three blood cell types. Flow cytometry reveals the absence of CD55 and CD59 on her red cells, which is a crucial clue. The key here is understanding that CD55 and CD59 are protective proteins that normally shield red blood cells from complement-mediated destruction. Their absence makes the cells vulnerable, leading to hemolysis, which explains her hemoglobinuria and anemia symptoms. So, what genetic abnormality causes this condition? The answer points to a mutation in the PIGA gene. This mutation impairs the synthesis of GPI anchors that attach these protective proteins to the cell surface. Without PIGA function, CD55 and CD59 can't be properly expressed, leading to the clinical picture we see. This example highlights how a specific gene mutation can directly impact cell surface proteins and result in disease. Recognizing these genetic connections is essential for understanding the pathophysiology and guiding diagnosis and management. Let's take a look at the answer here, which is A. Now. To understand this correctly, we need to focus on the explanation provided. Paroxysmal nocturnal hemoglobinuria, or PNH, actually results from a somatic mutation. That means it's an acquired change in the DNA that occurs in body cells after conception, not inherited from the parents. This mutation happens specifically in the PIGA gene, which is located on the X chromosome. The PIGA gene is crucial because it plays a key role in the synthesis of GPI anchors. These GPI anchors are important because they help attach certain proteins to the cell membrane. When there's a mutation in PIGA, the synthesis of these GPI anchors is affected, leading to the symptoms we see in PNH. So, understanding this genetic basis helps connect the dots regarding how the disease develops and manifests. This mutation essentially disrupts normal cell function, which ties into the broader theme of genetic and acquired factors in hematological disorders. Let's take a closer look at some of the mechanisms involved in conditions like PNH. First, we have platelet destruction by antibodies, which can lead to a decreased platelet count and bleeding issues. Then, there's excessive complement activation on platelets, which can cause their destruction and contribute to thrombosis. Autoimmune vasculitis is another factor. It's when the immune system attacks blood vessels, leading to inflammation and potential clot formation. Hypofibrinogenemia involves low levels of fibrinogen, impairing clot formation and increasing bleeding risk. Lastly, bone marrow fibrosis can disrupt normal blood cell production, including platelets, leading to various hematologic problems. Understanding these mechanisms helps us see how immune and hematologic factors interplay in diseases like PNH. This context is essential when considering complications such as thrombosis, which we'll explore further. Answer: B. So the correct answer here is B. And what's really important to understand is that complement-mediated platelet activation plays a central role in this process. This activation causes the platelets to become hyperactive, which leads to a hypercoagulable state, meaning the blood has a higher tendency to clot. And this excessive clotting is what we see as thrombosis, which is actually a hallmark feature of paroxysmal nocturnal hemoglobinuria, or PNH. So, in essence, the abnormal activation of platelets driven by the complement system is a key factor that contributes to the increased risk of clot formation in patients with PNH. Let's go through the options for initial testing in this case. The first one, the direct Coombs test, is useful for detecting autoimmune hemolytic anemia, where antibodies are attacking red blood cells. Next, flow cytometry for CD55 and CD59 is primarily used to diagnose paroxysmal nocturnal hemoglobinuria, a different type of hemolytic disorder. The Ham's acid test is a classic test for diagnosing G6PD deficiency, which causes hemolysis especially after oxidative stress. Urine hemosiderin assessment can help confirm hemolysis by detecting iron deposits in the urine, and a bone marrow biopsy is more invasive and generally reserved for other hematologic conditions. In this patient's scenario, with hemoglobin in urine but no red blood cells, along with elevated LDH and low haptoglobin, the signs strongly suggest hemolytic anemia. Since autoimmune causes are common, the direct Coombs test is often the best initial step to confirm immune-mediated hemolysis. It helps determine whether antibodies are involved in destroying the red blood cells. So the most appropriate first test here would be the direct Coombs test, as it allows us to quickly identify if the hemolysis is immune-related, guiding our next steps in diagnosis and management. Alright, so the correct answer here is B now. The key point to understand is that flow cytometry is actually considered the gold standard for diagnosing this condition. It works by detecting the absence of specific markers, namely CD55 and CD59, on the surface of red blood cells. When these proteins are missing, it indicates a particular type of hemolytic anemia, often related to complement-mediated destruction. So, in practice, flow cytometry provides a highly accurate and reliable way to confirm the diagnosis by directly assessing the presence or absence of these important surface proteins. This method really highlights how advanced diagnostic techniques can improve our accuracy in identifying different hematological disorders. Alright, let's look at the treatment options listed here. We have A. Eculizumab, B. Prednisolone, C. Allogeneic stem cell transplant, D. Iron supplementation, and E. folate. Now, in this case, we have a 36-year-old woman with PNH, or paroxysmal nocturnal hemoglobinuria, who is experiencing worsening anemia and needs frequent transfusions. She's asking about the definitive therapy, that is, the treatment that can potentially cure her condition. Out of these options, the only one that offers a true, curative potential is the allogeneic stem cell transplant. This procedure replaces her defective blood stem cells with healthy ones from a donor, aiming to eliminate the root cause of PNH. The other options, like eculizumab, are very effective at managing symptoms. They reduce hemolysis and prevent complications, but they don't cure the disease. Prednisolone can help with inflammation, but it's not curative. Iron supplementation and folate help manage anemia and support red blood cell production, but again, they don't address the underlying cause. So, when we're thinking about a definitive, potentially curative approach for PNH, the key point to remember is the allogeneic stem cell transplant. It's a complex procedure, but it offers the possibility of a cure for suitable candidates. Answer is C. Allogeneic bone marrow, or stem cell transplant, can be a curative option in certain cases. However, it's important to understand that this procedure is typically reserved for severe or more advanced cases due to its complexity and potential risks. So, while it offers a real chance for cure, it's not the first line of treatment for milder cases. This highlights the importance of carefully selecting patients who would benefit most from this aggressive approach. And of course, it ties into our overall discussion about treatment options and when to consider more intensive therapies. Let's take a closer look at some of the key vascular syndromes associated with thrombosis. First, we have Budd-Chiari syndrome, which involves hepatic vein thrombosis leading to liver congestion. Next is Trousseau syndrome, a paraneoplastic condition characterized by migratory thrombophlebitis, often linked to malignancy. Then there's antiphospholipid syndrome, an autoimmune disorder that predisposes individuals to clotting in various vessels due to antiphospholipid antibodies. Moving on, Paget-Schroeder syndrome, or effort thrombosis, typically affects the upper extremities in young, active individuals. And finally, May-Thurner syndrome involves compression of the left iliac vein, increasing the risk of deep vein thrombosis in that area. Now, in this specific case, we see a 45-year-old man with PNH, or paroxysmal nocturnal hemoglobinuria, presenting with sudden abdominal pain and imaging revealing hepatic vein thrombosis. This condition is actually called Budd-Chiari syndrome, which highlights how different syndromes can manifest with similar vascular complications. Recognizing these syndromes helps us understand underlying pathophysiology and guides appropriate management. So the correct answer here is A now. Let me explain why. Hepatic vein thrombosis, also known as Budd-Chiari syndrome, is a classic thrombotic complication that we see in patients with PNH, or paroxysmal nocturnal hemoglobinuria. This condition involves the formation of blood clots in the hepatic veins, which can lead to liver congestion and even liver failure if not addressed. Recognizing this association is key because it highlights the importance of monitoring for thrombotic events in PNH patients. It's a prime example of how the disease's hematologic abnormalities can translate into significant vascular complications. So, understanding this connection helps us to better anticipate and manage potential complications in our patients. Let's take a closer look at the lab abnormalities associated with chronic intravascular hemolysis in PNH. First, we see elevated haptoglobin levels. This might seem counterintuitive at first, because in hemolysis, haptoglobin typically decreases as it binds free hemoglobin. However, in some cases of ongoing hemolysis, especially in chronic settings, haptoglobin can be elevated due to liver response or other factors, so it's important to interpret this in context. Next, decreased LDH levels are noted here. Usually, in hemolysis, LDH is elevated because it's released from lysed red blood cells. So, a decreased LDH would be unusual in active hemolysis, but could be seen in specific contexts or stages, or perhaps when hemolysis is controlled or partial. Moving on, increased indirect bilirubin is a classic sign in hemolysis. As red blood cells break down, hemoglobin is metabolized, and unconjugated bilirubin levels rise, leading to jaundice and other symptoms. Then, decreased reticulocytes are listed here. This is interesting because in hemolytic anemia, we often see increased reticulocytes as the bone marrow compensates. So, decreased reticulocytes might suggest marrow suppression or an alternative process impairing red cell production. Finally, increased MCV, or mean corpuscular volume, can be seen in hemolytic conditions, especially when reticulocytes, which are larger than mature red cells, are elevated. But if reticulocytes are decreased, then increased MCV might be due to other factors, such as macrocytosis from vitamin deficiencies or marrow stress. Overall, understanding these lab findings helps us piece together the picture of chronic intravascular hemolysis in PNH. Recognizing the typical pattern, such as increased indirect bilirubin, is crucial, but we also need to interpret these values carefully within the broader clinical context. Answer: C. Now, let's talk about hemolysis and what it causes in the body. When red blood cells break down prematurely, it leads to an increase in indirect bilirubin, which is a byproduct of hemoglobin breakdown. You'll also see an elevation in LDH, or lactate dehydrogenase, an enzyme that is released during cell destruction. At the same time, haptoglobin levels decrease because it binds to free hemoglobin released into the bloodstream, and with more hemoglobin present, haptoglobin gets used up quickly. Additionally, the body responds to hemolysis by producing more reticulocytes, which are immature red blood cells, in an attempt to replace the lost cells. So these key lab findings, high indirect bilirubin, high LDH, low haptoglobin, and increased reticulocytes, are classic indicators of hemolysis and help us differentiate it from other causes of anemia. Let's take a look at this clinical scenario. A 32-year-old male with paroxysmal nocturnal hemoglobinuria, or PNH, who develops recurrent infections. Now, this is a key point because it indicates an issue related to his treatment. The question is, which drug among the options listed, rituximab, eculizumab, prednisolone, hydroxyurea, or azathioprine, is responsible for these infections? Focusing on eculizumab, it's important to understand that this medication works by inhibiting the complement system, specifically the terminal complement pathway. While this effectively reduces hemolysis in PNH, it also impairs the body's ability to fight certain bacterial infections, especially Neisseria species. This means that patients on eculizumab are at increased risk for serious, sometimes recurrent, infections because their innate immune response is compromised. So, in this case, the recurrent infections are most likely due to eculizumab. This highlights a crucial aspect of complement inhibition therapy. While it can be highly effective, it also carries significant risks that require careful monitoring and preventive measures, like vaccination. This example ties back to our overall theme of balancing therapeutic benefits with potential adverse effects, especially in immune-modulating treatments. So the correct answer here is B now, to explain why eculizumab is a monoclonal antibody that targets complement C5. This is a crucial part of the immune system's complement pathway, which normally helps fight off infections. By inhibiting C5, eculizumab effectively suppresses part of this immune response. However, this suppression can increase the risk of certain infections, particularly those caused by Neisseria species. Neisseria bacteria, such as Neisseria meningitidis, are normally kept in check by the complement system. When that system is compromised, as with eculizumab therapy, patients become more vulnerable to these bacteria. This point ties into the overall theme of understanding drug mechanisms and their potential side effects. It's especially important because, while eculizumab is effective for certain conditions, we need to be aware of these infection risks and monitor patients accordingly. Before starting eculizumab, it's crucial to ensure that patients are properly vaccinated against certain infections. The most important vaccine to administer beforehand is the meningococcal vaccine, because eculizumab increases the risk of meningococcal infections. While other vaccines like influenza, pneumococcal, hepatitis B, and tetanus are important for overall health, the meningococcal vaccine is specifically essential prior to initiating eculizumab therapy. This step helps protect patients from potentially severe or life-threatening infections that they become more susceptible to when on this medication. So always remember, before starting eculizumab, ensure the patient has received the meningococcal vaccine to mitigate this significant risk. Answer is B. The key point here is that the meningococcal vaccine is required before starting complement inhibitor therapy. This is really important because these therapies can increase the risk of meningococcal infections. So, ensuring patients are vaccinated beforehand helps protect them from potentially serious infections. It's a crucial step in managing the overall safety of patients on these treatments. Remember, vaccination is a preventative measure that plays a vital role in reducing infectious risks associated with complement inhibition. Now, let's take a closer look at some of the potential complications in this scenario. First, disseminated intravascular coagulation, or DIC, is a serious condition involving widespread clotting and bleeding, often triggered by severe illnesses or trauma. Next, cerebral venous thrombosis refers to a clot in the brain's venous sinuses, which can cause increased intracranial pressure and neurological symptoms. Then we have aplastic crisis, typically caused by parvovirus B19 infection, leading to a sudden drop in red blood cell production, particularly relevant in patients with underlying hemolytic disorders. Moving on, iron overload occurs when there's excessive iron accumulation, often due to repeated transfusions, which can damage organs over time. Lastly, hemolytic uremic syndrome involves the destruction of red blood cells and kidney injury, often following infections like E. coli. In our case, the woman with PNH, paroxysmal nocturnal hemoglobinuria, has a known risk for hemolysis, especially during pregnancy when the blood volume and immune activity change. The most likely complication here is hemolytic uremic syndrome, because it combines the hemolytic aspect with potential kidney involvement, which is a concern in PNH. Recognizing these options helps us understand how PNH can complicate pregnancy and guides us in monitoring and managing such patients effectively. Let's look at the answer here. B. Now, the key point to understand is that pregnancy actually increases the risk of thrombosis. This is an important concept because during pregnancy, the body is in a hypercoagulable state, which means there's a greater tendency for blood to clot. And one specific complication we need to be aware of is cerebral venous sinus thrombosis, or CVSD. This condition is a known complication in patients with PNH, or paroxysmal nocturnal hemoglobinuria. So, in summary, pregnancy can elevate thrombotic risks, making it particularly important to monitor and manage patients with conditions like PNH carefully. Now, let's look at the different types of hemolysis associated with PNH. First, we have extravascular hemolysis, which occurs when red blood cells are destroyed outside the blood vessels, usually in the spleen or liver. Then there's intravascular hemolysis, where the destruction happens directly within the blood vessels, leading to the release of hemoglobin into the bloodstream. There's also mixed hemolysis, which involves both intravascular and extravascular processes simultaneously. Additionally, splenic sequestration involves the trapping of red blood cells in the spleen, causing a reduction in circulating cells. Lastly, microangiopathic hemolytic anemia occurs when small blood vessel clots physically damage the red blood cells as they pass through. So, when considering PNH, the most characteristic type of hemolysis is intravascular, because the deficiency of protective surface proteins makes red blood cells more vulnerable to destruction directly within the blood vessels. This intravascular hemolysis is a hallmark of the disease and helps differentiate it from other types of hemolytic anemias. Understanding these distinctions is vital because it influences both diagnosis and management strategies in PNH. Answer B. Now, let's look at the key point here. PNH, or paroxysmal nocturnal hemoglobinuria, causes intravascular hemolysis. This means that red blood cells are destroyed directly within the blood vessels. The main mechanism behind this is complement-mediated lysis. Essentially, the complement system, which is part of our immune defense, mistakenly attacks the red blood cells in PNH, leading to their destruction. Understanding this helps us see why patients with PNH experience hemolytic anemia and related symptoms. So, the correct answer is B, because it highlights the core pathophysiology behind the disease process. Let's go over some key features we see in paroxysmal nocturnal hemoglobinuria, or PNH. First, elevated LDH, or lactate dehydrogenase, is common because it indicates ongoing hemolysis. When red blood cells break down prematurely, LDH levels go up. Second, low haptoglobin levels are also typical, since haptoglobin binds free hemoglobin released during hemolysis, and in PNH, this gets depleted. Third, the Coombs-positive hemolysis is important to note. It indicates an immune component, but in PNH, hemolysis is usually Coombs-negative, so this is a key point to keep in mind. Fourth, hemosideриnuria, which is the presence of iron-laden macrophages in the urine, reflects chronic hemolysis and iron overload from the breakdown of red cells. Fifth, pancytopenia, or reduction in all blood cell lines, can also be seen in PNH, especially if the bone marrow is suppressed or involved. Now, the question here asks which of these features is not typically seen in PNH. As we go through these, remember that while some features are quite characteristic, not all are universally present, so always consider the overall clinical picture when diagnosing. All right, let's look at the answer here, which is C now. When it comes to paroxysmal nocturnal hemoglobinuria, or PNH, a key characteristic is that it's Coombs negative. This is really important because it helps us distinguish it from autoimmune hemolytic anemia, which is typically Coombs positive. So, understanding this difference is crucial in diagnosis, as PNH involves a different mechanism. It's not caused by antibodies attacking the red blood cells, unlike autoimmune hemolytic anemia. Recognizing these distinctions helps us ensure we're considering the right diagnosis and treatment options. Let's look at some common causes of microcytic anemia in this context. First, iron deficiency from chronic hemoglobinuria can occur because ongoing hemolysis leads to iron loss through the urine, which eventually results in iron deficiency. Next, folate deficiency, although more often associated with macrocytic anemia, can sometimes contribute but is less common here. Myelodysplasia involves abnormal bone marrow development, but it typically causes more diverse blood cell abnormalities rather than isolated microcytic anemia. Inflammation, on the other hand, can cause anemia of chronic disease, but that usually results in normal or slightly decreased serum iron levels, not profound iron deficiency. Lastly, malabsorption, such as from gastrointestinal conditions, can reduce iron absorption and lead to deficiency. Given this patient's ferritin level of 12 micrograms per liter, which is quite low, and the presence of microcytic anemia, the most likely cause is iron deficiency due to chronic hemoglobinuria. This highlights the importance of understanding how ongoing hemolytic processes can deplete iron stores over time, leading to anemia. This case ties into the overall theme of how different mechanisms can cause anemia, emphasizing the need to consider the patient's clinical context when evaluating these laboratory findings. All right, let's look at the answer here, which is A. What this is telling us is that chronic urinary loss of iron, specifically through hemoglobinuria, can actually lead to iron deficiency over time. When iron is lost in the urine regularly, the body can't replenish it fast enough, and this ongoing loss results in a deficiency. This concept is important because it highlights one of the ways iron deficiency can develop beyond the more common causes like inadequate intake or poor absorption. It ties into the overall theme of understanding the various mechanisms behind anemia and iron deficiency, emphasizing that persistent iron loss through urine is a significant factor to consider in diagnosis and management. So, in this case, We have a 40-year-old woman with PNH who continues to experience recurrent thrombosis despite anticoagulation therapy. This situation highlights that anticoagulation alone might not be sufficient for her management. Now, when considering additional therapies, we need to look at options that target the underlying disease process more directly. For example, rituximab is an anti-CD20 monoclonal antibody primarily used in certain lymphomas and autoimmune conditions, but it's not typically used for PNH. Eculizumab, on the other hand, is a complement inhibitor that has revolutionized PNH treatment by preventing the destruction of red blood cells and reducing thrombosis risk. Then there's IVIG, which is often used in immune-mediated conditions but isn't standard for PNH. Plasmapheresis can be useful in some autoimmune scenarios, but it's not a long-term solution for PNH. Lastly, cyclophosphamide is a potent immunosuppressant, but again, it's not the mainstay for PNH management. Given this, the most appropriate additional therapy for this patient would be eculizumab, as it specifically targets the complement pathway involved in PNH, helping to prevent further thrombosis and hemolysis. This case underscores the importance of understanding targeted therapies that address the root mechanisms of the disease, especially when standard anticoagulation isn't enough. Answer: B. Now, let's look at why this is the correct choice. Eculizumab works by reducing hemolysis, which is the destruction of red blood cells, and it also helps lower the risk of thrombotic complications, or blood clots. It achieves this by specifically inhibiting the complement system, which plays a key role in the pathology of certain blood disorders. So, by blocking complement activation, eculizumab can prevent some of the severe consequences associated with these conditions. This is a crucial point because it highlights how targeted therapies like eculizumab can improve patient outcomes by addressing the underlying immune processes. Connecting this to the overall theme, it shows the importance of understanding complement's role in hemolytic and thrombotic processes and how we can intervene effectively. Let's look at some potential mechanisms behind acute kidney injury in a patient with PNH. First, immune complex glomerulonephritis can cause kidney damage through immune deposits that trigger inflammation, but this is less common in PNH. Next, the deposition of hemosiderin in renal tubules occurs when there's ongoing hemolysis, leading to iron overload in the kidney tissues, which can damage the tubules directly. Then we have renal artery thrombosis, which is particularly relevant here. PNH is known for its increased risk of thrombosis, including in the renal arteries, and this can acutely block blood flow, causing ischemia and injury. Amyloidosis involves abnormal protein deposits, but it's more of a chronic process rather than an acute event. Lastly, hypovolemia, or decreased blood volume, can reduce renal perfusion. But in PNH, the primary concern is the thrombotic occlusion of renal vessels. So, of these options, renal artery thrombosis stands out as the most direct and plausible mechanism explaining acute kidney injury in PNH, because it causes sudden loss of blood flow to the kidneys, leading to rapid damage. Recognizing this helps us understand the importance of managing thrombosis risk in these patients to prevent such critical complications. Let's look at the answer, which is B now, to understand why. We need to follow the chain of events that occurs in chronic intravascular hemolysis. First, the ongoing destruction of red blood cells releases hemoglobin directly into the bloodstream. This excess hemoglobin then passes through the kidneys, leading to hemoglobinuria, where you see hemoglobin in the urine. Next, the kidneys try to handle this overload, and the hemoglobin gets taken up by the renal tubules. Over time, this results in the deposition of hemosiderin within the tubular cells. This accumulation indicates ongoing damage and stress to the renal tissue. Ultimately, if this process persists, it can cause progressive kidney damage, leading to renal failure. So, understanding this sequence, from chronic hemolysis to hemoglobinuria, hemosiderin deposition, and eventually renal failure, is key to grasping how intravascular hemolysis impacts kidney health. This ties into the broader theme of how different hemolytic conditions can have systemic consequences. Let's take a closer look at the possible mechanisms behind pancytopenia in this 33-year-old man with PNH. First, bone marrow aplasia could be a cause, where the marrow fails to produce enough blood cells. Second, splenomegaly might lead to increased sequestration and destruction of blood cells, reducing their numbers. Third, vitamin B12 deficiency can impair DNA synthesis, leading to ineffective hematopoiesis and pancytopenia. Fourth, hemolysis, which is common in PNH, results in the destruction of red blood cells, but it can also cause a broader impact on blood cell counts through increased turnover. Finally, immune destruction plays a role when the body's immune system mistakenly targets and destroys blood cells, contributing to pancytopenia. Understanding these mechanisms helps us grasp how different processes can lead to this condition, especially in the context of PNH, which involves complex interactions between hemolysis and immune pathways. Alright, so the correct answer here is A now. Let me explain why. Paroxysmal Nocturnal Hemoglobinuria, or PNH, often overlaps with aplastic anemia, and that's mainly because they both involve issues with the bone marrow stem cells. In essence, the stem cell defect affects the production of blood cells, which is a common link between these two conditions. Recognizing this overlap is important because it influences how we approach diagnosis and treatment. Understanding that PNH can coexist with or even develop from aplastic anemia helps us better grasp the complexities of bone marrow disorders and their management, which is a key part of the overall theme of this presentation. Let's review the management options for this patient. First, eculizumab immediately. This is a targeted therapy that can be very effective in controlling hemolysis in PNH, especially in more severe cases. Next, bone marrow transplant. While it can be curative, it's usually reserved for cases with severe marrow failure, and it's a significant procedure with considerable risks. Moving on to C, observation and monitoring. This might be appropriate here since he's asymptomatic with a small clone, but we need to weigh that carefully. Then, D, prednisolone. Steroids are not typically the mainstay of PNH management and are more useful in other hematologic conditions. Lastly, E, warfarin. Anticoagulation is important in PNH due to the risk of thrombosis, but if he's asymptomatic and has a small clone, immediate anticoagulation may not be necessary. Overall, in this scenario, close observation with regular monitoring is often recommended initially, especially since he's asymptomatic with a small clone size. Alright, let's look at this question. The answer here is C now. What's really important to understand is that when we encounter small, asymptomatic clones, the best approach is usually observation. There's no need to jump into immediate treatment in these cases. The key point is that these small clones, especially when they aren't causing any symptoms, often don't require intervention right away. Instead, we monitor them closely to see if they change over time. This fits into our broader theme of personalized, cautious management, avoiding unnecessary treatments when the situation doesn't warrant it. So remember, not every abnormal finding needs aggressive action. Sometimes, watchful waiting is the most appropriate course. Now, let's take a look at some of the key laboratory markers used in evaluating PNH. We have serum haptoglobin, reticulocyte count, LDH, MCV, and ferritin. Each of these gives us different insights into what's happening in the body. Starting with serum haptoglobin, this protein binds free hemoglobin released during hemolysis. In cases of active hemolysis, serum haptoglobin levels tend to decrease because it's being consumed rapidly. Next, the reticulocyte count reflects how the bone marrow is responding to anemia. An elevated reticulocyte count indicates that the marrow is trying to compensate for ongoing hemolysis by producing more red blood cells. Then we have LDH, or lactate dehydrogenase. This enzyme is released when red blood cells are destroyed, so elevated LDH levels are a strong indicator of active hemolysis. Moving on to MCV, or mean corpuscular volume, which tells us about the size of red blood cells. While it's less specific for hemolysis, changes here can help us understand the type of anemia present. Finally, ferritin measures iron stores. In chronic hemolysis, iron gets recycled, but ferritin levels can sometimes be low if iron deficiency develops. Now, to answer the question, which of these is a marker of disease activity and hemolysis in PNH? The most direct and reliable marker among these is LDH, because it reflects ongoing red cell destruction. Elevated LDH levels are typically seen during active hemolysis episodes, making it a key marker for disease activity in PNH. Answer: C. Now, let's talk about why that's the correct choice. LDH, which stands for lactate dehydrogenase, is an important enzyme we measure in these cases. It correlates very well with intravascular hemolysis, meaning when red blood cells are breaking down inside the blood vessels. This makes LDH a useful marker for assessing hemolytic activity. Additionally, it's closely linked to PNH activity, so elevated LDH levels often suggest active disease. Understanding this relationship helps us monitor disease progression and response to treatment effectively. So, in summary, LDH is a key indicator because it reflects ongoing hemolysis associated with PNH. Let's take a closer look at the progression to aplastic anemia. This can occur through several mechanisms, including folate deficiency, which impairs DNA synthesis and leads to marrow failure. Iron overload is another factor. While it mainly results from transfusions, it can also contribute to marrow suppression over time. Drug-induced cytopenia is also important. Certain medications can cause direct toxicity to the bone marrow, leading to pancytopenia. Lastly, hypersplenism can cause increased destruction of blood cells, resulting in cytopenias. Now, in the context of our patient with PNH, who presents with worsening fatigue and lab results showing significant anemia, leukopenia, and thrombocytopenia, we need to consider which of these mechanisms is most likely responsible. PNH often leads to hemolysis, but when you see pancytopenia like this, it suggests something more profound affecting the marrow itself. Given this presentation, the most common underlying cause is marrow failure, which points us toward aplastic anemia. And as we've discussed, the pathways leading there include factors like folate deficiency, drug effects, or hypersplenism. But in this scenario, the key is recognizing the pattern of pancytopenia in a PNH patient, which strongly suggests marrow failure rather than isolated hemolysis. All right, let's look at this slide. The answer here is A, which refers to aplastic anemia. Now, the key point to understand is that when you see pancytopenia along with signs of marrow failure, it suggests that the bone marrow is no longer producing enough blood cells across the board. This pattern indicates an evolution towards aplastic anemia, which is a condition characterized by the failure of the marrow to generate these cells. Recognizing this progression is important because it helps us differentiate aplastic anemia from other bone marrow disorders, guiding appropriate diagnosis and treatment. So, in summary, the presence of pancytopenia and marrow failure points us toward aplastic anemia as the likely diagnosis. So, in this case, we have a 38-year-old woman who is on eculizumab, and she reports dark urine again after she delays her dose. Now, let's consider what could be causing this. One key point to remember is that dark urine often indicates hemolysis, or the breakdown of red blood cells. In patients on eculizumab, a complement inhibitor, there's a risk that if the medication is delayed or missed, the protective effect wanes. This can lead to complement reactivation, which in turn causes relapse of hemolysis. So, among the options, the most likely reason here is disease relapse due to complement reactivation. It's a reminder of how critical adherence to the dosing schedule is in preventing hemolytic episodes. Other causes, like drug-induced hemolysis or antibody formation, are less likely in this context unless there's a new drug exposure or new antibody development. Iron deficiency and myelodysplasia are also less relevant here since they don't typically cause this sudden darkening of urine after a dose delay. So the main takeaway is that missing or delaying eculizumab can lead to relapse of complement activity, resulting in hemolysis and symptoms like dark urine. This highlights the importance of maintaining proper dosing to keep the disease well controlled. Answer: A. So the correct answer here is option A. And the reason for that is, if we stop or delay eculizumab treatment, the underlying process of complement-mediated hemolysis can actually come back. This means that the hemolysis, which is the destruction of red blood cells driven by the complement system, can recur if the medication isn't continued properly. It's a key point because it highlights the importance of maintaining consistent therapy with eculizumab to prevent a relapse of hemolysis. This ties into the overall theme of the presentation, which emphasizes the crucial role of ongoing treatment in managing conditions like this effectively. Let's take a closer look at paroxysmal nocturnal hemoglobinuria, or PNH for short. This is a rare acquired blood disorder that affects the red blood cells. The key feature here is that these cells become unusually vulnerable to destruction by the body's own immune system. This leads to episodes of hemolysis, or red blood cell breakdown, which often occur at night or in the early morning, hence the term nocturnal. One important aspect to highlight is that PNH results from a mutation in stem cells in the bone marrow. This mutation causes a deficiency of certain proteins that normally protect red blood cells from destruction. As a result, patients can experience symptoms like anemia, fatigue, and dark-colored urine, especially in the morning. Understanding PNH is crucial because it ties into the broader themes of our presentation, how immune dysregulation can lead to various hematologic conditions. Recognizing these key features not only helps in diagnosis, but also guides us toward targeted therapies that can significantly improve patient outcomes. Let's take a closer look at PNH, which stands for Paroxysmal Nocturnal Hemoglobinuria. It is a rare disorder that actually arises from acquired changes in stem cells, specifically hematopoietic stem cells. This means it's not inherited, but develops during a person's life. In PNH, these abnormal stem cells produce blood cells that are unusually vulnerable to destruction by the complement system, which is part of our immune response. This leads to complement-mediated intravascular hemolysis, meaning red blood cells are being destroyed inside blood vessels, often causing anemia and other related symptoms. Another key feature of PNH is pancytopenia, which is a reduction in all types of blood cells, red cells, white cells, and platelets, leading to a range of issues such as fatigue, increased risk of infection, and bleeding problems. Additionally, thrombosis, or blood clots, is a serious complication associated with PNH. These clots can form in unusual locations and significantly increase the risk of morbidity. Overall, understanding PNH helps us appreciate how a single disorder can affect multiple blood components and lead to complex clinical manifestations, tying into our broader discussion on hematologic disorders. Let's talk about this acquired somatic mutation in the PIGA gene, which is located on the X chromosome. This gene plays a crucial role in the synthesis of GPI, or glycosylphosphatidylinositol, anchors. These GPI anchors are essential because they attach important proteins to the surface of cells. Now, when there's a loss or mutation in PIGA, the production of GPI anchors is disrupted. As a result, surface proteins like CD55 and CD59, which rely on GPI anchors to stay attached, are no longer present on the cell surface. This loss is significant because these proteins normally protect cells, especially red blood cells, white blood cells, and platelets, from being attacked by the complement system, which is part of our immune defense. Without these protective proteins, the cells become vulnerable and can be lysed or destroyed by the complement system. This process is at the heart of the pathophysiology we're discussing. Essentially, the mutation causes a deficiency in key surface proteins, leading to increased cell destruction and contributing to the clinical features of the disease. This connection underscores the importance of GPI-anchored proteins in maintaining cell integrity and immune regulation. Let's talk about hemolysis. In this condition, the destruction of red blood cells occurs within the blood vessels, which is known as intravascular hemolysis. Interestingly, this process often worsens at night, leading to what we call morning hemoglobinuria, where the urine appears dark due to the presence of free hemoglobin. When testing for causes like autoimmune hemolytic anemia, the Coombs test usually comes back negative, indicating that the immune system isn't attacking the red cells. Patients often present with symptoms like fatigue, pallor, and jaundice, which are signs of anemia and increased breakdown of red blood cells. Laboratory findings support this. We see elevated LDH levels, which reflect cell destruction, increased indirect bilirubin from hemoglobin breakdown, decreased haptoglobin because it binds free hemoglobin, and an increase in reticulocytes as the bone marrow tries to compensate for the loss. These features are key to recognizing hemolytic anemia and understanding how the body responds to the rapid destruction of red blood cells. Let's talk about thrombosis. It's a condition that can occur in some unusual sites in the body, such as the hepatic vein, which can lead to Budd-Chiari syndrome. It can also occur in the portal vein, mesenteric veins, and even cerebral veins. These locations are less common, but when thrombosis happens there, it can cause serious problems. Thrombosis is a major cause of both morbidity and mortality, meaning it can significantly impact a patient's health and can even be life-threatening if not managed properly. Now, moving on to the key clinical features. These are the signs and symptoms we look for when diagnosing thrombosis. Recognizing these features is crucial because early detection can make a big difference in outcomes. So, in summary, thrombosis in these unusual sites is not just a rare occurrence. It's a serious condition that requires our attention. Understanding its clinical features helps us catch and treat it more effectively, ultimately improving patient care. Today, we're going to discuss pancytopenia and bone marrow failure, which are often due to a defect in the stem cells. Essentially, when the stem cells in the bone marrow are damaged or dysfunctional, it leads to a reduction in all three blood cell types, red cells, white cells, and platelets, resulting in pancytopenia. This condition can sometimes overlap with other disorders like aplastic anemia, where the bone marrow fails to produce enough blood cells, or myelodysplasia, which involves abnormal development of blood cells. Understanding these overlaps is important because they can influence both diagnosis and treatment strategies. Now, let's focus on the key clinical features. Patients typically present with symptoms related to anemia, such as fatigue and pallor, due to low red blood cells. They may also experience increased infections because of white cell deficiency and bleeding tendencies because of low platelet counts. Recognizing these signs early is crucial, as it points us toward underlying marrow failure. So, in summary, pancytopenia from bone marrow failure is a complex condition with significant clinical implications, and understanding its core features helps us manage it more effectively. Let's talk about renal complications associated with hemolytic conditions. When hemoglobin is released into the bloodstream, it can lead to hemoglobinuria, which is the presence of hemoglobin in the urine. This might sound benign at first, but it actually has significant consequences for the kidneys. The free hemoglobin gets filtered through the kidneys and can deposit as hemosiderin within the renal tubules. Over time, this accumulation causes damage and can lead to chronic kidney injury. Now, what are the key clinical features to watch for? Patients might present with signs of hemolysis, such as dark-colored urine, which indicates hemoglobinuria. Additionally, ongoing renal damage might manifest as declining kidney function, with symptoms like edema or hypertension. Recognizing these features early is crucial because they highlight the importance of managing hemolytic episodes promptly to prevent long-term kidney damage. This process underscores how interconnected hemolytic events are with renal health, emphasizing the need for careful monitoring and intervention to protect kidney function in affected patients. Let's talk about iron deficiency today, specifically in the context of chronic urinary iron loss, which we often see as hemoglobinuria. This means that iron is being lost through the urine over time, leading to a deficiency. Now, when we consider the key clinical features of iron deficiency, it's important to recognize that patients might present with symptoms like fatigue, pallor, and weakness, all stemming from the reduced hemoglobin levels. These signs are crucial because they reflect the body's struggle to get enough iron for proper red blood cell production. Connecting this to the overall theme, understanding how chronic urinary iron loss contributes to deficiency helps us better diagnose and manage these cases effectively. Remember, catching these features early can make a significant difference in patient outcomes. Now, let's look at some of the screening or classic tests we use to identify intravascular hemolysis. One key test is checking for urine hemosiderin or plasma-free hemoglobin. The presence of hemosiderin in the urine indicates that red blood cells are breaking down within the blood vessels, releasing hemoglobin that's filtered by the kidneys. Similarly, elevated plasma-free hemoglobin levels also point to intravascular hemolysis. These findings are critical because they help us confirm ongoing destruction of red blood cells inside the vessels, which is a hallmark of certain hemolytic conditions. So, in summary, these tests are essential tools for diagnosis, allowing us to identify intravascular hemolysis early and accurately, and they fit into the larger picture of diagnosing hemolytic anemias. Now, let's talk about the confirmatory test, which is flow cytometry. This test looks for the absence or reduced expression of CD55 and CD59 on both red and white blood cells. These are important markers because their deficiency is characteristic of certain conditions, such as paroxysmal nocturnal hemoglobinuria. When we see reduced or absent CD55 and CD59, it helps confirm the diagnosis. Essentially, this test provides a more definitive answer after initial screening, tying together the clinical picture and initial lab findings. So, understanding how flow cytometry works in detecting these specific markers is key to accurately diagnosing these conditions. Now, moving on to some of the obsolete tests that were historically used for diagnosis. These include Ham's test, also known as the acid hemolysis test, and the sucrose lysis test. Both of these were once common tools in the diagnostic process, but they've been replaced by more advanced and accurate methods. Specifically, flow cytometry has now taken over as the preferred technique. The key point here is that these older tests provided valuable insights in the past, but with technological advancements, we now have more precise and reliable options for diagnosis. It's a great example of how diagnostic methods evolve over time to improve patient care. Now, let's discuss some of the key complications that can arise. Thrombosis is one of the most serious concerns, and it can affect various critical areas such as the hepatic, cerebral, and abdominal veins. This kind of clot formation can have severe consequences, especially when it involves vital organs. Next, renal failure can occur, often as a result of hemoglobin nephropathy, which happens due to the damage caused by abnormal hemoglobin or hemolysis. This highlights how blood disorders can directly impact kidney function. We also need to be aware of the risk of developing aplastic anemia, myelodysplasia, or even transformation into acute myeloid leukemia. These are significant hematologic complications that can significantly alter the course of a patient's health. Another important point is iron deficiency, which can develop from chronic blood loss. This can lead to anemia and further complicate the clinical picture. Lastly, there's an increased risk of infections, particularly when therapies involve complement inhibition. Since the complement system plays a crucial role in immune defense, inhibiting it can predispose patients to serious infections. Overall, these complications underscore the importance of vigilant monitoring and proactive management to mitigate these risks and improve patient outcomes. Let's go through the key treatment options and their purposes. First, we have eculizumab, which is an anti-C5 monoclonal antibody. It works by blocking the terminal complement activation, which helps to reduce hemolysis and the risk of thrombosis. This is typically a lifelong therapy, given its role in controlling the disease process. Next, ravulizumab is similar in function but longer-acting, so it can be administered intravenously every 8 weeks, providing convenience for patients. Before starting any complement inhibitor therapy, vaccination against meningococcal infection is essential, since these treatments can increase susceptibility to such infections. Supportive therapies also play a crucial role. They include folic acid, iron supplementation, and transfusions if needed, to manage anemia and support overall health. Anticoagulation therapy might be necessary for patients at risk of or with existing thrombosis, helping to prevent clot formation. Finally, allogeneic stem cell transplant is considered the only curative option, but it's reserved for severe cases, especially those with marrow failure or refractory disease. Overall, these treatment strategies are aimed at controlling symptoms, preventing complications, and improving quality of life, and they should be tailored to each patient's specific needs. Thank you so much for your attention today. I really appreciate you taking the time to be here. I hope the insights and concepts we've discussed have been helpful and inspiring for your own work. Remember, the key takeaways are about how we can apply these ideas to make a positive impact. If you have any questions or want to explore these topics further, please feel free to reach out. Once again, thank you for being such an engaged audience. I look forward to seeing how you all take these concepts forward.